Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. So we're going to do something a little different this morning. I woke up, I had some thoughts to talk about, and then I'm scrolling my Instagram feed and I see some responses to the Clipboard thing that I posted yesterday. And there was this big discussion that these two people got into an argument about, well, how am I supposed to chart with as busy as we are in New York City? And somebody had a counter to that. And then the New York City person was like, started throwing the terms like, well, you must be from Queens East or Brooklyn East. Like, nobody gives a fuck about your geography. Nobody is impressed by where you work. And I see the same thing from the Philly people all the time. I'm not saying this is a New York City thing. And I've seen this when I've gone around the country teaching or at conferences like, oh, well, I'm a Phoenix EMS provider. Or you see the Philly thing all the time around here. Yeah, I work in Philly. Like, we're super busy. Nobody cares about your geography. I get it. I have worked urban EMS. When I was an EMT, I worked in the city of Wilmington. Not that Wilmington is a huge city, but it is a little shithole. Very busy, lots of trauma, lots of volume. I think in 2003, when I worked there, the unit PA1 was in Firehouse Magazine, put out a top 20 busiest EMS units in the country, and it made that list. I've worked as a medic in an urban environment. I worked as a paramedic on the busiest unit in the state for a couple of years. So look, I get it. Overwhelmed with volume, but I see a lot of busy systems. If I may be totally honest, I can see that breed lazy skills and bad habits because I have been there working in the urban environment. And I'm not saying this is everybody, and I know some people are going to get pissed off, but I have seen a lot of walking out to the ambulance and sit on the bench seat, and I'll just get your demographics, take a blood pressure, and once we get to the hospital, here's a wheelchair into the waiting room. There is an endless amount of calls like that. Does that necessarily make you a better provider because you work in the big city? No. I am sure that there are medics in the Podunk, Western District of Sussex County, Delaware, in little Botetourt County, Virginia. I taught in Happy Jack, Arizona, which is in the middle of nowhere. I bet you the providers from there can run circles around. I'm not saying urban medics. I'm not saying big city medics because there are awesome medics in big cities and urban medics. I'm saying that these people could probably run circles around the providers whose only justification for their worth or experience is the geographical location that they work in. That's just what I'm saying. So why did I bring up this Clipboard thing, and what could I possibly be talking about here? Let me pull this up. There was a post by the Galveston or Houston Fraternal Order of Police that one of their members, I may be getting the details wrong, actually, let me pull it up. Stand by to stand by. Okay. All right. It was from the Galveston Municipal Police Lodge 435. One of their members was at some water park incident during a swiftwater training exercise. The member was trapped underwater for 90 seconds. CPR was administered, so a critical drowning patient. And it's a Galveston EMS arrived on scene. And unfortunately, EMS waited over 20 minutes to leave the scene, which at my first thought, I was kind of like, all right, cops, drive in your own lane. Maybe I don't advocate for sitting on scene for a long time, but 20 minutes, it's not terrible. And I was kind of thinking maybe they're doing resuscitation. Maybe they are coding the patient, which should not be done in transport to the hospital. Maybe what they were doing was completely appropriate patient care. And you, FOP, are just being a bunch of whiny little bitches. But then I read the next sentence. Or I'm sorry, it wasn't the next sentence. It was the second part of that sentence. So unfortunately, EMS waited over 20 minutes to leave the scene, blah, blah, blah. Due to one EMT needing to train the other on entering information into the computer system. Officers with Galveston PD and the sheriff's office requested to drive the ambulance and or to start transport, but were told to mind their business and allow EMS to do their job. To say we are disappointed in Galveston EMS would be an understatement. Blah, blah, blah. Holy shit. And I hate to say it, I was not there, but I can totally see this happening, because as great as the clipboard forms where you get all the patient demographics and information in one nice little succinct piece of paper, or the tablet, I have seen that completely water down, negate the care and assessment that is provided by some providers. I have seen providers clutching on to that clipboard like it isn't their lifeblood. And they walk in and immediately, what's your name? What is your date of birth? Okay, now what is going on? Where is a list of meds? Because right here, I have to write your list of medications down. And do you have any allergies? Meanwhile, they have no idea what the fuck is going on with the patient. They are just clipboard automatons. I responded to a syncope call a couple of weeks ago, and a BLS service showed up. Now, BLS services that run in the southern end that I routinely run with, this was none of you. And I know sometimes people listen to this podcast, they're thinking like, were you talking about me? No, this was not you. This was a company that we normally don't get in our geographical area. They were doing mutual aid and they came down from a more northern part of the county. But this crew comes in. I'm just saying that because I don't want people to get upset, because I know that my friends and colleagues listen to this podcast. So this crew comes in. They're perfectly nice. I've been on scene for like 5 minutes. I'm doing my thing. I did a 12 lead. I'd started a line. And this EMT comes in with the iPad and immediately comes up to the scene and is entering in information. What is your name? What is your date of birth? And I wanted to take that goddamn iPad out of her hands and throw it across the room. The clipboard or the iPad does not do your assessment for you. I posted an Instagram graphic and I said, normalize not bringing in a clipboard or tablet as a first in piece of equipment. When you go in, screw the demographics. Do we have to get them? Yeah, critically important. But go in, make patient contact, find out what is wrong with the patient, do an assessment, and then if they need any treatments right then and there, render the treatments. Then worry about getting the medication list. Then worry about the social security number. So some of the people in the comments, and this is where that, for lack of a better term, retarded discussion from the New York City medic came into play, was that, well, if we're a busy system, like you chart when you can, which I certainly get. I don't necessarily agree with the people who say that you should never be charting in front of the patient. I don't agree with that at all. Somebody wrote a comment, and it was a genuinely good and constructive comment. It was like, no charting in front of the patient. If you can take time away from the encounter to chart, you should be able to talk to them more and then find another question to ask. Which, okay, I do though think that sometimes we go crazy with our question asking. I'm all about complete assessments, doing comprehensive assessments, but I do sometimes see people start to ask questions that are like space age stupid and just completely not pertinent. Like, so tell me about your hysterectomy in 1962 when you're there for an ankle fracture. I routinely chart in front of the patient. It's how modern healthcare is. Go into a hospital, go into the ICU. The doctor comes in doing rounds. What's the doctor probably have in front of them? A cart with a laptop that they are pushing in front of them. Computers, tablets, charting systems, EMRs. It's modern healthcare, whether you like it or not. And yes, once everything is done with the patient, I will then chart on the iPad on the way to the hospital. I certainly am not doing it in their house. I certainly am not doing it in the acute phase when I'm finding out what is going on with the patient. I think that's inefficient. I think it's stupid. And I think you can argue that it is unprofessional. But if I got a 45-minute ride to the hospital, I've done everything for the patient. I've had a nice conversation with the patient. I'm sitting next to them and I say, hey, I'm right here If you need anything, let me know. I'm going to work on the chart a little bit because I do understand that you do chart when you can. If you have 14 charts to do, the end of your shift might not be optimal because one, who wants to stay a couple extra hours to chart? Two, how are you going to remember everything? I mean, I am 42 years old now. My memory recall is not as great as it was when I was 22. So yes, I will chart on the iPad on the way to the hospital. It's just like everything else. Be smart about it. If the patient wants to talk to you and they want to have a conversation with you on the way to the hospital, then yeah, I think it's kind of a dick move to put an iPad between you and that patient. Even if you're not interested in what the patient is saying, just fake it. Be a human, converse with them, put the iPad down, talk to the patient. But if they're one of these patients who just wants to rock out and relax because they feel like crap, you're running some IV fluid into them, you've given them Zofran, you've given them nitroglycerin, or you have them on a cardizem drip or whatever, hell yeah, I am going to be plugging along on that iPad, getting the chart done. And I pride myself on having that chart done by the time I get to the hospital. But that is just me. But the clipboard or the iPad or tablet, whatever you use, is not a friggin' first in line piece of equipment. And the second part of this conversation is that if your only justification for your worth as a provider is the geographic location in which you work, I would be willing to bet, if I was playing the odds, probably not that good of an EMS provider. Okay. Let me move on to another topic. Let's talk about video laryngoscopy. Video laryngoscopy should be first line for every intubation that you do. DL, you do need to be good at your DL. It needs to be available as a backup, but video should be first line on everything. You get some backlash when you say this, though. I've gotten backlash on this. Haney got a shitload of backlash from people when he posted something about that. But video laryngoscopy is the way to go. The data is clear. It skyrockets your first pass success rate. Isn't that what it is all about? It's about the patient. It's not about validating your awesomeness as a skill. I remember, he's a great paramedic guy that I work with. I have had the privilege of watching this guy over the last couple of years grow and evolve from a novice into a paramedic that when he shows up on scene or I respond to a call with him, I'm like one, I enjoy it because I enjoy working with him, but also very solid. But when we hired him, he was like a 1-year paramedic, maybe. And we have this neurotrauma patient that we are going to RSI or SAI because we're in Pennsylvania and we don't have RSI. And I keep hearing that it's going to be coming. I have been hearing that rapid sequence intubation is coming to the Pennsylvania protocols for the 17 years that I have been a certified paramedic in the state of Pennsylvania. I don't believe that RSI is coming. I will believe it. I see it. Anyway, we're doing a etomidate intubation on this neurotrauma guy. And my buddy gets in the back of the ambulance. He's a 1-year paramedic. And I was like, hey, why don't you do the tube? I've got plenty this year. And I see him bust out the DL. And I was like, you don't want the video? And he was like, no, I don't like using the video. And right then and there, in the back of the ambulance and in front of the BLS crew, I put him on the spot and I said, oh, from all of your massive experience intubating patients. So he goes in, he DLs the guy, and he can't get the tube. I go in with VL, super easy tube, lickety split, get the tube. Lesson learned for him. He now uses VL and he's doing a great job and he loves VL. But yeah, DL you have to be good at. It is your backup. But VL should be first line for everything. Why wouldn't you want to use it? It makes your life easier. I don't get these skills jockeys that feel the need to like validate their awesomeness by performing skills the old school way. Like blah, 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 whatever. If you're listening, you can't see. If you're listening on Spotify or Apple or whatever and not watching this on YouTube, you can't see that as I said that I was kind of making a jacking off motion and rolling my eyes. So I get this question from a paramedic student in my DMs, and it was an earnest question. Thank you to whatever your name was for reaching out. I don't have the question in front of me, but he said, I hear all this great stuff about video laryngoscopy. I understand that I don't have a lot of experience. He said, but I seem to like DL much better than video. Is there something wrong with me? And I told him, yes, there is something very wrong with you. No, I'm kidding. I told him, I think, one, it is a lack of familiarity with your equipment. And two, you're probably not being adequately trained. And we all know that there are a lot of pitfalls and inadequate training that happen in paramedic programs. I don't know your particular paramedic program. I have to say, I see a common theme of inadequate training, inadequate skills preparation, tubing the same dummy over and over again, tubing the same mannequin, an instructor just loosely watching the person as they put the scope in and they go, oh, tube in, good job. And it's like they're really not watching their technique and critically appraising it. I see a lot of that. I saw a paramedic school last year post that they were using a vomit simulator, which is great. Vomit simulators, they're really easy to make. They're low budget and they're phenomenal airway training. But they posted a picture of them using the vomit simulator, and they, like, 3 of the pictures they posted, they showed the students intubating them with the patient positioned in the completely wrong position. So there is inadequate airway training, and I think that might have been what was at play there. There is a technique. If you don't use the right technique for the respective device that you're using, you can and will fuck it up. Like, we use the McGrath. I like to use a hyperangulated blade. It's something new over the last year that I've started using. I really like the hyperangulated blade. I've seen people fuck up using the hyperangulated blade because they use a bougie. You shouldn't use a bougie with a hyperangulated blade. You should use a rigid stylet. I've seen people screw up because they try to act like it's DL, or when they go in and they sweep the tongue to the left. No, with VL, you go in straight midline. I've seen people not engage the vallecula. The vallecula is a big thing when using a curved blade. Paramedic training programs, I don't think, teach students to appreciate the vallecula. The entire point of the curved blade is to go into the vallecula. I hear people say, oh yeah, I use a Mac 4 on everything. You know, sometimes I just use it as a straight blade and lift everything up. No, that is the wrong technique. The tip of the Mac blade, whether you're using DL or VL, is designed to go into the vallecula. You go against that little line in the middle of the vallecula that is called the hyoepiglottic ligament. You apply a little bit of pressure and lift up, and that engages that ligament, and it will pop the epiglottis, lift it up, and you will get a nice view of the chords. I see people fuck that up with VL technique. You must engage the vallecula when using a curved blade. But every device is a little bit different. I've used most of the devices out there, like the King Vision. It's a bulky device. That is one of the pitfalls. I've used the McGrath. I've used the CMAC. They're very similar. I think the CMAC gives you a better picture, but I like the feel of the McGrath better. And I feel like the blade is a little bit less bulky than the CMAC. So there's different little nuances, some big, some little, with each device. And you've got to do reps, tons and tons and tons of reps to get good at the device. Yeah, video laryngoscopy makes it a lot easier. It makes your first pass success rate go up. But it's like anything else. You got to be good with the tool. If you handed somebody an AR-15 with all of the high dollar optics equipment and you told them to hit a target, they're probably going to have much more efficacy at hitting that target than if you handed them an old Revolutionary War musket. Yeah, the AR-15, it's a great tool. It makes life a lot easier. It's a lot more accurate. You still have to know how to use it. You have to be good with it. You have to know how it works. You have to know all the little nuances and variables with it to really master it, even though it's much better than that Revolutionary War musket. I feel like VL and DL is a similar thing. You got to be good at your device. You got to train it. You got to know it. And once you learn to know it, you're going to love it. And you're never going to want to go back. And the final thing that I want to talk about is when supervisors attack. I had a conversation with a medic this week. I'm talking to him, and he tells me about this really hot call that he had. And the patient was super injured. It was an unsafe scene. There was a lot going on. There were children in the residence. I don't want to give everything away, but it was a very bad scene. Very critically injured patient as well. And this guy is probably one of the best paramedics I've ever worked with and is a cool cat under pressure. And he is venting to me, and he tells me that things were going well until the supervisor showed up. And the supervisor had the effect of ramping everything up into overdrive and throwing kerosene onto a fire. So what do you do when a supervisor attacks? This supervisor, I'm told, showed up on scene, started giving orders for things that weren't appropriate, and then started to challenge the medic who had been running the call when the medic wanted to do things that were clinically appropriate. And I'm listening to the things that the medic is telling me that the supervisor wanted to do that were inappropriate, and then said no to things that this medic said he was going to do that were clinically appropriate. And it really was like, did this supervisor just show up because it was a hot call and he wanted to be like top shot in charge and make all the decisions and turn the call into something that it wasn't? So what do you do when a supervisor attacks? One is you have to be constructive about it. You want to be firm, but you need to be constructive. And that's what my buddy did. The way he handled it, the way he told me about it was perfectly appropriate. He said he kind of laid down the law, was very firm, but he was not disrespectful and he was not aggressive. To handle a situation like this, slow the supervisor down and make them realize that they are putting everything into overdrive. And one of the ways that I have accomplished this, and it's not just with supervisors, it's with other providers. I worked with a flight nurse who was like this before, is I have stopped them. I have literally put my hand on their shoulder and I have said, what is it that you are trying to accomplish? What is the goal here? Like, let's slow down. What is the goal here? I have found that that is effective at kind of recentering somebody who is running at Mach 5,000 speed. I also think that it is important to explain your rationales for things. So let's use an example of a needle decompression. Let's say you show up to a chest trauma patient and they do indeed have chest trauma, but they don't have any signs of a pneumothorax. Let's say that they were shot in the chest, but that they have good lung sounds bilaterally. They have a good pulse ox. They have a good blood pressure. There is no indication that they have a tension pneumothorax, and you only decompress a tension pneumothorax. We do not decompress simple pneumothoraces. We also do not decompress pneumothoraces that we think are going to develop into a tension pneumothorax. I saw that a lot in the comments this week, and I was kind of like, eh. And I went, not because I was judgmental, but because this is something that younger me used to fuck up. I used to decompress people that probably didn't need to be decompressed because my rationale was I don't want them to develop into a tension pneumothorax. And it took some time for me and somebody to finally explain to me into a way that I could conceptualize that if they don't have a severe pneumothorax, you're going to cause worse of an air leak into the pleural space because you're going to injure the lung. So you have the pleural space and you have the lung right underneath of it. In a pneumothorax, there is air between that pleura and the lung. If it becomes a severe pneumothorax, a tension pneumothorax, it is going to push that lung tissue far away from the pleural. So there is a large pocket of air. You put your needle in, you hit that pocket of air, and you relieve it. If it's only a minor or a moderate pneumothorax and there's really not that much air and you put a needle into the chest cavity, you're going to hit lung tissue. And then that's going to cause a lung laceration and they are going to leak air out of their alveoli. So we don't decompress pneumos that we think are going to be tension pneumos. We only decompress pneumos that are tension pneumos. So another comment I saw, going down a bit of a rabbit hole here, but there's no script and this is a fun thing to do and this is my podcast, so let's do it. Another comment that I frequently saw is that, well, why are we going to wait for the patient to crash? Valid point. And I respectfully say this, And I generally don't like to be the person who flexes and says like, "Oh, I've done 7,000 of these because I work in New York City." No, I have done a shitload of needle decompressions of tension pneumothoraces. If they truly have a tension pneumothorax that is the problem, and that is what's causing their blood pressure to be 40/20 and the patient to be unconscious, and you release that tension, they will immediately get better. Like almost like giving Narcan to an apneic overdose patient. It is a dramatic improvement. They're going to immediately get better. It is a quick fix. So it's also not a perfect thing. It's not like we're the hospital and we can just put chest tubes in. And I think this is a colorful entry into talking about that we should just get away from needle decompressions because I think they're extremely problematic. We fuck them up a lot. I think we should be doing finger thoracostomy because I think it's safer. It's a more dramatic procedure. There's a little more steps to it, but I think that we should be doing fingers because it is safer. Where was I? So let's say, going back to the supervisor thing, let's say that the supervisor shows up and says, "Hey, you got to put a needle in that patient's chest." And you don't agree with that because the patient does not have a tension pneumo. They don't have any suspected pneumothorax, but there's a bullet hole in the chest, and the supervisor is zeroing in on that as justification for darting their chest. I think that you need to be firm, respectful. I think you need to methodically provide your rationale for stuff. I think you need to say, I did not dart the chest. I don't think we need to because this patient has stable vital signs. They have good lung sounds on that affected side, and there's no respiratory distress. Or if they're intubated, they're not difficult to ventilate. Their pulse ox is good. I think you need to clearly state your case, and I think that you need to be courageous. I would use the word courageous and say, I do not think that what you want to do is clinically appropriate based on these criteria and the findings that I just laid out. And say it respectfully, but say it firmly. I must be honest that I see a lot of people talk about disagreements and interactions with other providers or supervisors, and they don't speak up. They just get angry. They'll talk shit. They'll vent about it later. But in that heat of the moment, they will not stand up for what they think is appropriate. So they would just let the supervisor dart the chest and then just talk shit about it. And then they'd be like, "Oh, well, the supervisor told me to do it. What choice did I have?" No, you have to stand up. Nurses do this in the hospital constantly. This is one thing that nurses are really good at, is that let's say a doctor, often it's residents, not shitting on residents, but they will want to do something. And a lot of times the nurses will just be like, no way, we're not doing that. That is not appropriate. Nurses are really good at speaking up to doctors who are at a higher level and are supervisory over them. It should be no different. So be respectful, be firm, and clearly, methodically, and intelligently state your logic. I could keep going, but I think I've rambled a lot. So this was totally unscripted. I'm going to edit out the ums and the pauses and the stuff. I'm going to edit this a little bit, and I'm interested to see how this turns out because I had absolutely no outline script, nothing, not Ashley here or another guest to help me with the discussion. So we'll see how it goes. Let me know if you liked it. Let me know if you hated it. I'll put it out, and you guys have a good weekend. Take care.